Good afternoon, everybody. Welcome to the second seminar of the new academic year here at the Geary Institute for Public Policy. Before we begin, I'd like to remind you that questions can be directed to the chair through the Q&A function and will be dealt with at the end of the seminar, unless, of course, you have a question that needs clarification during the presentation. Today, I'm delighted to welcome John Cullinan as our speaker. John is an Associate Director in Economics at the J.E. Cairns School of Business and Economics at NUIG Galway. His research interests focus on the causes and consequences of socioeconomic and geographic inequalities in the areas of health, disability, and education. He has published his research in a number of leading international peer-reviewed journals, including Health and Place, Environmental and Resource Economics, Journal of Epidemiology and Community Health, Spatial Economic Analysis, Ecological Economics, and Health Economics. Today, John is going to be addressing the question of, is mammography screening an effective public health intervention, evidence from a national experiment? So John and his colleague Patrick Moran in this paper exploit a national experiment resulting from the phased implementation of the Irish National Mammography Screening Programme. And they will be examining the impact of screening on breast cancer outcomes from both a health service and a population perspective. So without further ado, John, over to you.
Thank you very much, Darren, and thank you to all of you who are joining today. Good afternoon. It's great to be giving another Geary seminar. Unfortunately not in person this time, but hopefully I'll get to see former colleagues and some of you in the future. So as the introduction suggested, this paper is titled, "Is Mammography Screening an Effective Public Health Intervention, Evidence from a Natural Experiment?" And it's joint work with Pat Moran, who at the time that we were doing the work was at the School of Medicine at Trinity College. He's still affiliated with the school there, but he's now working at Deeper. So what I'd like to do is just sort of right at the start, because there's quite a lot in this paper, and I'm not going to have time to get through everything today. So what I'd like to do is maybe sort of give you the key take-home messages from the paper, and in particular what I'm going to be focusing on in the talk. So as the title of the paper suggests, what we do is we examine the impact of a publicly funded population breast cancer screening program in Ireland. And as you'll see, to do so, we use the phased geographic rollout of the program as a natural experiment. So in terms of the overall conclusions, and this is what I'm really going to be trying to focus mainly on today, we conclude that the overall benefits from population-based screening are likely to be much lower than is generally thought amongst the general population, but even maybe amongst policymakers and healthcare providers. And specifically in terms of, say, some of the analysis, we find no effect on overall population breast cancer mortality or all-cause mortality. As well as that, we find very little evidence of any significant reductions in socioeconomic disparities in the different outcomes that we consider. And our main conclusion then is that our results call into question the overall effectiveness of this very common and very often quite popular public health intervention. And, you know, as you can imagine, perhaps that's a somewhat controversial and maybe even a surprising finding for many, given how popular, you know, some screening programs, in particular breast cancer screening programs, are in Ireland and also internationally. So I'm hopefully going to get a chance to sort of tease through why I think that is the case in my talk today. Okay, so I'll start in terms of, you know, a little bit of discussion of the broad context for the paper. Breast cancer is the most common cancer globally. It's the second most common cancer amongst Irish women, and it's the fifth leading overall cause of cancer deaths worldwide. And as I'm sure most people will know, it's obviously much more prevalent in women, but maybe also important to note here that men can get breast cancer too, but obviously way more prevalent in women. The incidence of breast cancer tends to be much higher in more developed countries, but so too is survival from breast cancer. So in terms of incidence, the known risk factors include things like age, nulliparity or older age at first birth, the use of oral contraceptives or hormone replacement therapy, as well as sort of lifestyle factors that relate to things like diet or alcohol consumption or cigarette smoking. So they're well established and known risk factors for developing breast cancer. And in terms of survival then, there's very good evidence to show that better survival is generally attributed to early diagnosis, but also, and this can be related, superior access to treatments. And if you look at, cross-country variation or even within country variation in survival rates, what you'll very often notice is that there are quite stark socioeconomic disparities in terms of outcomes. And that's something that I'm going to be speaking about today. And, the other thing I suppose that's important here at a sort of a fairly broad level or in terms of the broader context is that as well as the very sort of obvious adverse health and other consequences to women who are affected by breast cancer and to their families as well, the economic burden of breast cancer is generally acknowledged to be very significant. So one study, for example, from the American Cancer Society in 2010 put a sort of a global societal cost in around $88 billion. And I know sometimes as economists we might take some of those numbers, with a pinch of salt, but I think the evidence is fairly convincing that there are wide economic and wider societal costs associated with breast cancer. So because of all that, there are a range of different health policy responses. So for example, you'll all be very aware of various information campaigns and preventative measures around breast cancer. And these would include things like general awareness to promote early diagnosis. So we might, for example, have campaigns that look to encourage more self-examinations or self-checks, for example, so that you can diagnose the cancer earlier. And then there would be, preventative measures would include things like trying to control risk factors relating to obesity or alcohol and tobacco consumption. So those sorts of information campaigns encouraging preventative measures, for example, are very, very common. And the other very common health policy response is something called mammographic screening. And again, I know or appreciate that most people will have a reasonable familiarity with mammography, but it's basically the process of using low energy X-rays to examine the human breast. And the idea, and this is a really fundamental idea for the paper that I'm going to present today, is that the idea of mammography is that it's designed to reduce breast cancer mortality by, first of all, detecting asymptomatic cancers. So this is basically, before they present clinically, and to do so at an early stage as opposed to a late stage. So if you can detect the cancer early at as opposed to stage 3 or stage 4, for example, then the idea is that the treatment is likely to be more effective. And on the basis of those sorts of ideas and the way in which mammographic screening is designed to work, the World Health Organization recommends population-based mammography screening for women, all women aged 50 to 69 years in settings where it's safe and okay to do so. Partly as a result, I guess, of this WHO recommendation, but other reasons as well. What we now find is that there are population-based screening programs in most high-income OECD countries. But I would note here that there are some exceptions to this. So some countries are looking at whether or not they want to continue with their screening programs, and other certain regions and certain countries have decided not to do so. And right at the outset, it's important, I guess, to stress that the evidence to support these population-based screening programs, or at least the introduction of these screening programs initially, is based on 11 randomized controlled trials that were conducted between 1963 and 1991. So this is going back, quite some time. Some of these trials are almost 60 years, and that, those trials represent a significant portion of the evidence base for these population-based screening programs. Now, in relation to the evidence from those trials, there's quite a bit of disagreement in relation to what exactly they say in terms of, what reduction in breast cancer mortality, for example, is implied from those RCTs. And there's some quite heavy hitters in this area. So there's quite, some big names who've worked in this area. And just to give you a flavor of maybe some of the disagreement, even in relation to the original RCTs, in 2013, Sir Michael Marmot published a paper in the British Journal of Cancer, I think it is. And that research was based on research commissioned by the British Cancer Society. And Marmot was asked basically to review the evidence in relation to screening programs and to make recommendations in relation to what he thought were the benefits. And basically, there's a number of things in the paper, but I think two of the most interesting sort of conclusions in the paper are, first of all, that Marmot concluded that the only reliable and relevant evidence on screening was the evidence from those original RCTs. And he conducted a meta-analysis from the RCTs, and he concluded that population-based screening is associated, or actually leads to, a 20% reduction in breast cancer mortality. So screening is causing a really significant decrease in breast cancer mortality. So it's very, very effective according to Marmot's review of those 11 RCTs. But at the same time, Peter Gotcha and Carsten Jorgensen conducted a Cochrane review, and they reviewed the same RCT evidence, but they cast some doubt over the quality of the evidence and the quality of the randomization in some of the trials. And they stated or concluded that if you excluded the trials where there were maybe some concerns around randomization, actually what you're finding are quite modest impacts associated with screening. So quite a bit of disagreement between, say, the two papers, even though they were reviewing the same evidence base and doing so at the same time. And interestingly, and this is very relevant for what I'm going to present today, Marmot was quite strong in his paper in reviewing the RCT evidence in discounting the usefulness of studies that are based on observational data. So obviously, since these RCTs have been conducted, there's been lots of screening programs internationally and a lot of data. And Marmot sort of casts a lot of doubt over the quality of evidence that can be gathered or developed using observational studies. And even related to that, since the Marmot and the Gotcha reviews, for example, and over the last sort of 20, 30 years of the existence of these screening programs, there's been an awful lot of debate and disagreement as to whether or not the sort of benefits that maybe are suggested from the original RCTs, like Marmot is suggesting, that they are actually realized in contemporary population-based screening programs. So there's issues around external validity of the trials, for example, and things like crowd out effects and other possible reasons why what you observe in the RCT mightn't actually happen in the real world. A lot of people have used a lot of different methodological approaches and lots of different data to try and understand whether or not breast screening is leading to significant decreases in mortality. And let's just say there's widespread disagreement in relation to that as well. Okay, so on the benefit side, if you like, in terms of reductions in breast cancer mortality from these screening programs, there's disagreement in relation to the evidence that sort of forms the basis for the existence or introduction of these programs, but also a lot of disagreement in relation to what the benefits of these programs have been since they've been rolled out, particularly based on these sorts of the observational studies. So that's the benefit side of screening. There's also it's also very important to talk about the range of different costs that are potentially associated with screening. So in any sort of screening program, you're likely to have false positives and false negatives. So they're sort of a natural consequence of screening programs by the definition of screening. But when it comes to mammographic screening, there's another really important cost that deserves quite a bit of attention, and that's something called overdiagnosis. So overdiagnosis occurs when women are correctly diagnosed with breast cancer, but the disease would never have produced symptoms or resulted in any other health problem. So to think about that, basically, imagine a woman goes for a screen, the breast cancer is detected, and she is therefore diagnosed with breast cancer. If she had never gone, in the case of an overdiagnosed case, if she had never gone for screening, she would never have been made aware that she had cancer. She would have lived her whole life without becoming aware that she had breast cancer, and she would have been completely unaffected by that breast cancer. In other words, some of these cancers don't develop to a point where they actually have any impact on the woman at all. And that has two implications. The first implication is it causes a problem in terms of understanding whether or not the diagnosed cases from screening are actually problematic or not, because it's not possible to distinguish an overdiagnosed cancer from what we might term a problematic cancer. And the second problem, or what becomes the main problem here, is because you can't distinguish between an overdiagnosed and a problematic cancer, the overdiagnosed case needs to be treated. Okay, and that could include things like chemotherapy and so on and so forth. So very, invasive, very intrusive, and difficult interventions, and some of those, needlessly so. And lots of people have looked at estimated rates of overdiagnosis. A pretty good study, I think, from the US is one by Blair and Welsh. They estimated an overdiagnosis rate of about 31% for non-invasive and invasive cancers. Others have found higher rates, others have found lower rates. And once again, much like the benefit side of screening, on the cost side, there's quite a bit of uncertainty in relation to what the actual overdiagnosis rates are. So, basically, I guess one of the points we make in the paper is that ultimately, like everything, when it comes to screening programs, the case for having a national population-based screening program basically boils down to weighing up the costs and benefits, okay? Or at least that's how I justify an economist getting involved in this kind of work. We argue that we need better evidence, number one, to make the case for screening programs. So what are the benefits? What are the costs? What is good quality evidence to actually inform those decisions? But we also need it at another level, which is to help women to make more informed decisions in relation to attending for screening. Now, what I would say here is that our paper is not in any way concerned with the second point here. We can't use what we find in our paper to help women make more informed decisions. Our paper is purely concerned with the overall case for screening programs, and in particular looking at the benefit side of that equation. Okay, so that is a very sort of broad introduction to the breast screening, the breast cancer screening area, and that's the sort of the strong motivation for what we do in our paper. And then in terms of what we actually do in the paper, there are three main aims. So the first aim is we look to estimate the impact of a breast cancer screening program using quasi-experimental methods. And in terms of, say, our first sort of key contribution, what we're going to do is we're going to look at two outcome measures. And I'm going to discuss these outcome measures in a bit more detail subsequently, but we look at basically case fatality, which is essentially the probability of dying from breast cancer within a certain time period, conditional on being diagnosed with breast cancer. And then we also look at population mortality, which is the rate of breast cancer mortality in the population. So we look at these two different key outcomes, and we think that's important for reasons I'm going to get into subsequently. Previous research hasn't looked at these two outcomes, and we're essentially going to show that it's possible to have pretty dramatic decreases in case fatality, but ultimately not find enormous changes in population mortality. Okay, so that's the first aim of the paper and the first, I think, key contribution. The second key contribution is not only do we look at these key outcome measures, but we also try and understand how these outcome measures are changing and why they're changing. So we investigate what we call the pathways to changes in case fatality and population mortality. So we look at things like how did screening impact the number of breast cancer cases? How did it impact mode of presentation? Was it symptomatic or asymptomatic, for example? We look at stage of diagnosis. Is it an early stage cancer? Is it a late stage cancer? And we also try and examine rates of overdiagnosis in the Irish context. So basically the idea here is, and I think this is a good contribution of the paper, is, if we see a change in case fatality, for example, then why is that? And if we don't see a change in population mortality, then why might that be? So that would be the second aim of the paper. And then the third aim of the paper, which is one that I won't sort of have time to talk about in a huge amount of detail today, is we also look to consider the role and importance of socioeconomic status for screening related outcomes, and in particular, whether or not screening reduces socioeconomic inequalities. Because you might think of a public health intervention as having a sort of primary objective of reducing breast cancer mortality, but also maybe a secondary objective in terms of, tackling socioeconomic inequality. So we'd like to know whether or not that happens. I'm going to show you some evidence in a little while that shows that the inequalities, the disparities in outcomes across socioeconomic status are pretty stark in Ireland. So that is the third aim of the paper. And it's quite a long paper. There's quite a lot in it. I'm obviously not going to have time to discuss everything today, but if there's any of these sorts of issues that I don't discuss in enough detail for you in my presentation, come back to me in the discussion, and I'm happy to get back to those. Okay, so what I'll do now is I'll move to the specific context for our paper. So I'm going to talk about BreastCheck, which is the Irish breast cancer screening program, which many of you will be aware of. And it currently invites all women aged 50 to 64, not 50 to 69 currently, which is the WHO recommendation, but all women aged 50 to 64 in Ireland are invited to attend for 2-view mammography every 2 years. I see a question coming in the chat. Darren, well, I don't know, do I need to? Yeah, so BreastCheck is extended to age 50 to 69 in recent years. So that's ongoing as far as I know. I don't know if that's actually been finalized. It was certainly intended that BreastCheck would be rolled out to all 64 to 69 or 65 to 69-year-olds by 2021. I don't know what's happened with COVID in relation to whether or not that's fully happened, but the aim is to move to 50 to 69, absolutely. So the way the program works is that screening is provided free of charge. Women are notified by letter at least 7 days in advance of their appointment. It's very easy to reschedule if it doesn't suit. And then basically what happens is you get your invite and then you attend one of 4 dedicated screening centres. These are co-located with 4 large urban hospitals, but there's also a large number of mobile units that move around the country and cover regional areas. And what I'd like to say at the outset, because you'll see the main conclusions coming in a moment, which is sort of suggestive that this program is not working, maybe in terms of the primary objective of reducing breast cancer mortality. What I would say is that by all measures and international standards, BreastCheck is an excellent and high quality operation and program. It works extremely well in terms of what it's designed to do, which is to detect asymptomatic cancers, reduce late stage incidence, and reduce breast cancer or case fatality. I'm going to show you some evidence of that. Okay, so it's a really good program. Now, in terms of the rollout of the program, this is where it's useful for us in terms of trying to estimate its impact. So breast screening in Ireland, before BreastCheck actually existed, was first introduced as a pilot program. I think that pilot program was called the ECHOS program, and it was introduced in 3 counties from 1989 to 1994. And those 3 counties were Cavan, Monaghan, and North County Dublin. So over the period 89 to 94, the pilot program existed in 3 counties. And then what happened 6 years later was the actual BreastCheck program was rolled out to women from 11 counties in the east of the country in February 2000. So women living in these 11 counties, less the pilot counties, so 8 counties in total, women living in these 8 counties in the east of the country are going to represent our treatment group, because they will basically have received the intervention, which is the BreastCheck program. They will have been invited to attend for screening and have been able to avail of screening. And then what happened over the subsequent years is that the program was gradually extended to 4 other counties between March 2004 and April 2007, before starting in the remaining 11 counties, mainly in the west of the country, in December 2007. So women living in these remaining 11 counties in the west of the country, where screening became available, and basically at the start of 2008, they are going to represent our control group. And as I'm going to show you in a moment, basically the idea here is that this phased geographic rollout of the BreastCheck program gives us a natural experiment to try and evaluate the impact of screening. And in the paper, we discussed the reasons as to why we're reasonably confident that the rollout was exogenous, and it wasn't influenced, for example, by differential rates of breast cancer incidence or breast cancer mortality across the country. We think that, you know, these were made for practical budgetary reasons and also to capitalize on the existence of the pilot program. So we think that Rollout was actually exogenous. And this is kind of what it looks like. Okay, you've got, I don't know if you can see my cursor here. Maybe someone could give me a thumbs up or a thumbs down if you can't see my cursor. We've got the three sort of I don't know, shaded counties: Cavan, Monaghan, and we can, great, Mark, thank you. Whoops. We've got these three counties here where the pilot was conducted, and then you've got these light grey 8 counties in the east of the country. This is going to be our treatment group. Okay, so women living in these 8 counties are our treatment group. Women living in the dark grey counties, 11 counties in the west, are going to represent our control or our comparison group. We're essentially going to compare outcomes for women living in the light grey eastern counties to women living in the dark grey western counties. And for reasons I can talk about it at the end if people wish, we exclude Roscommon, Wexford, Carlow and Kilkenny from our main analysis. Now we do lots of sensitivity analysis and checks, but they are excluded from our main analysis, and I'm not going to talk about those today. Okay, so on to data. We have really high quality data. So we have data on the incidence of invasive breast cancer from the National Cancer Registry of Ireland, NCRI. So this is really high quality. I think well over 99% of cancer cases are included in the registry. And what's really important here is that what we have is for every breast cancer case that's diagnosed in each year, we have basically information on, number one, the mode of presentation. So was it clinical or asymptomatic? We have information on the stage of incidence. Was it early or late stage? We have information on the woman's age in 5-year age band. So for example, 50 to 54. And we also have information on the area level deprivation of the ED that the woman lives in. So we're able to, or we're given actually in the data set, quintiles of deprivation from richest to poorest, 1, 2, 3, 4, 5. So we know basically, or we use as a proxy, their area level deprivation as a measure of, or a proxy for socioeconomic status. But what's really important is we know basically in each year if a woman has been diagnosed with breast cancer and this additional information. Unfortunately, we don't know what month or even the date that the woman was diagnosed. We only know the year. So for example, in 2000, we know the number of women diagnosed with breast cancer, and then we know all of the supplementary information about them. And what we've done is we've linked, or rather, I think the NCRI have done this, is that they've linked death certificate data that's been supplied by the CSO, and that records the date and cause of death where relevant. So we know, for example, if a woman is diagnosed in 2000, we know whether or not she's died within, say, the subsequent 10 years. So we know what year she would have died. And we also know whether she died of breast cancer, some other form of cancer, or some non-cancer related reason. So what we're able to do is for every woman who's diagnosed in every year that we have our data for, we're able to determine whether or not they survive 10 years or more, or whether or not they've died within X number of years, for example. And that allows us to calculate what are called incidence-based measures of mortality and fatality. You know, for a given year, has the cohort of women diagnosed with breast cancer, what proportion of them have survived, for example, for a number of years. And overall then what we have is a sample of over 33,000 cases. So this is the total number of breast cancer cases in Ireland between 94 and 2011 for women aged 35 to 79 years. Now, in the main analysis I'm going to present today, we only use a subset of that data. We focus on the screening eligible 50 to 64 year age group, and we don't look at all of the years, but in some of the sensitivity checks and placebo testing that we do, we use younger and older women, for example. But we have a big, large sample of data, unfortunately, because it's obviously breast cancer cases. And you know, that does give us some statistical power in order to be able to detect changes, and that's our overall sample size. Now, what I'd like to do before I present the results is to go through and talk a little bit about the 2 outcome measures in a little bit more detail, because it's not always immediately obvious what exactly we're modeling. We're modeling both case fatality and population mortality in the paper. So a little bit of an explanation on those outcome measures, I think might be useful. So what I want you to do so that we're all really clear about how this works. Imagine in a given year, say the year 2000, there's a population of 100 women. And in that year, imagine or assume that 10 of those 100 women are diagnosed with breast cancer, and that within the next 10 years, 2 of those 10 women die from breast cancer. What that would mean is that the case fatality rate would be 20% for the year 2000. 20% of women diagnosed with breast cancer have died within 10 years from breast cancer. That's the case fatality rate. It's essentially a conditional probability. It's a probability of dying conditional on being diagnosed. The population mortality rate is a little bit different. That is the number of women who've died from breast cancer who were diagnosed in the year 2000 as a proportion of the population in that year. So in the year 2000, there were 100 women, and 2 of those were diagnosed and died within the subsequent 10 years. And that's a population mortality rate of 2%. Now, both of these are examples of what are called incidence-based fatality or mortality rates. It's conditional, or they're measures based on when the actual diagnosis was made. And the idea here is that what we want to do is we want to measure the impact of screening on both the case fatality rate and the population mortality rate. Ultimately, what you really want to see for an effective program is a reduction in the population mortality rate. And the reason for that is that screening can impact both the numerator and the denominator when it comes to the case fatality rate. It can impact both the number of women who die, but also the number of cases. Okay, so that's the idea of breast cancer screening. But when it comes to population mortality, it only impacts the numerator, or should impact the numerator. It's not going to have any impact on the number of women. Okay, so the difference between these two is essentially the denominator. And that's something that that's important to bear in mind as we go through the results. And then in order to try and understand how screening is impacting on these main outcome measures, we do a bunch of stuff in the paper. And I'm not going to get into all of the details of this today because I just quite simply don't have time. But we do some simple diff and diff calculations. We have a bunch of sort of fairly standard two-way fixed effects regression models that we have estimated with and without controls, and we put some interactions in there. For those of you who are maybe sort of interested in the econometrics, because we don't have a panel, we have what are called repeated cross sections. We're basically pooling data from different years pre and post the introduction of screening. We don't have to worry about any of the sort of the new fancy diff and diff literature. We don't have differential timing concerns or heterogeneous treatment effect concerns in the context of our models. One issue that we potentially had to deal with was what are called compositional changes in the populations. I won't get into that today, but it just meant we had to estimate some matching diff and diff estimators as well, and that all seemed to work out fine. And the other thing we do in the paper is the usual sort of placebo and falsification tests. And if there's time at the end and if people are interested, I can show you an example of some of those. But what I would like to, instead of going through all the nitty-gritty of the technical sort of estimations, what I would sort of like to focus on here is what do we need for identification in order for us to argue that we've actually estimated the impact, or the causal effect of the screening program. What do we need in order for us to argue convincingly that we've identified an effect? Because essentially what we're doing in the paper is comparing changes in breast cancer outcomes in the screening group to changes in the control group over the same time period. We're using the control group, basically women who live in the West, as the counterfactual for what would have happened to women in the East had they not received the intervention, which is the screening program. And in the paper, we do a lot of work to argue, look, that there's 3 key underlying assumptions that need to hold and that we've addressed them. The first is the standard sort of parallel trends assumption. It says any differences between the screened and unscreened groups are constant over time, absent screening. So that's standard stuff. You can't prove it, but you can show evidence to suggest that it likely holds. And I'll show you some of that in a moment. The other really important one in the context of screening programs is whether or not there are spillover effects. So is it the case that maybe treating one group causes changes in behavior in the other group? If women in the West engage in more opportunistic screening because they're aware of women in the East, for example, who are availing of the screening program, that will be problematic to us. So we investigate whether or not there are spillover effects, and we don't believe there are. And then the final underlying assumption, just as a technical one in terms of the composition of the populations. I won't say anything more about that unless people want to hear about it. Okay, so maybe now just turn to the results and talk you through those and try and give you a sense of what it is we're finding and why we think they're relevant and important. So what I have in this slide here are 4 panels in the chart, which give us a sense of how screening impacted on the breast cancer patient cohort. So we call this in the paper the health service perspective. We look at, conditional on being diagnosed with cancer, how has the screening program impacted your likelihood of presenting clinically, presenting with a late stage cancer, and then the probability that you die of breast cancer or some other reason within 10 years. So if you look at the top left, or the top left portion of our panel of the figure, what you find is that before the introduction of screening in the East in 2000, rates of clinical or asymptomatic presentation are really, really high. They're almost 100%. They're in the very, very high 90% for both the treatment and the control group, but drop significantly once screening is introduced in the East, in the treatment area or region, and they're only equalized then again a year or so after screening is introduced in the control or the comparison group in the West. So this is pretty clear evidence here that you have parallel trends prior to the introduction of screening in relation to clinical presentation. Screening causes a large decrease in clinical presentation amongst those diagnosed, and then subsequently they become very close after the whole country is in receipt of the screening program. You find something similar in terms of late stage incidence. The treatment region sees a marked decrease in late stage incidence. And what that all means is that because women are being detected asymptomatically at an earlier stage, breast cancer case fatality starts to fall in the East of the country. So if you look at basically this nice pattern, say prior to pre-trends prior to 2000, 10-year breast cancer case fatality is very similar in both the treatment group and the control group. And it's only after the introduction of screening that things start to change. And in particular, breast cancer case fatality falls significantly in the East. And similarly, you find all-cause case fatality also decreasing. So what this looks like is conditional on being diagnosed, you're much less likely to die within 10 years based on being a breast cancer case in terms of the health service perspective. It looks from this as if screening is working really well because case fatality is going down. And okay, I'm going to skip over some of the numbers here because I think maybe a little bit short on time, and we might come back to them if people have specific questions. But what we'd like to know really is not whether or not the cohort of breast cancer cases are actually doing better in terms of survival, but how actually survival and breast cancer mortality in the overall population is actually being affected by the introduction of the program. So again, what we do in terms of our analysis is to move from the health service perspective then to undertaking what's called a population perspective. And instead of just looking at, say, for example, the proportion of women who present clinically or the proportion of women who die within 10 years, what we now look at are, for the various outcomes that we look at rates per 100,000 of the population. So for example, if you look at clinical presentation in the East and the West, or the treatment and the control prior to the introduction of screening, they're very, very similar. But after the introduction of screening in the East, what we find is rates of clinical presentation go down. So that's a good thing because we're picking up more asymptomatic cases, and you can see a large increase in asymptomatic presentation in the treatment group post 2000. So that's exactly as we would expect. Now, when it comes to late stage incidence, what we find is very little change in the proportion or the rate at which women are presenting with late stage cancers. Now, there are some good technical reasons for this. You wouldn't expect ordinarily to see a massive drop off in late stage incidence when cancer screening is introduced. But you might expect to see some change, and we see only a very modest decrease in late stage incidence in the treatment group. But what we do find is a large increase in the population in terms of early stage incidence. So the screening program is picking up a lot of early stage cancers. And what that means is essentially that when it comes to then looking at how the screening program has impacted on either overall breast cancer mortality or all-cause mortality amongst breast cancer patients in the population, actually we're not finding big increases, I should say, or sorry, large decreases associated with the screening program. So this is sort of the rate of breast cancer mortality in the population. This again would be measured as sort of a number like 70 or 75 cases per 100,000 population. And what we find is, looking at breast cancer mortality rates, we don't see a significant difference or divergence in the treatment group compared to the control group. And it's somewhat something similar in terms of the all-cause mortality rates. And obviously, you know, these are just the pictures of what's happening in terms of our data. We estimate models and do all of the statistical analysis as well. And when we do that, what we find is very marginal decreases in breast cancer mortality. We don't find them to be statistically significant. And similarly, in terms of all-cause mortality, they're certainly nowhere near the estimate that Marmot has put forward in his paper that I discussed earlier, in terms of a 20% reduction in breast cancer mortality. We're finding much lower reductions. And as I said, they're not statistically significant. So just in the last couple of minutes, I'll just mention a couple of things we do in the paper to sort of try and, you know, convince the readers, I guess, that that actually what we've identified here is the effect of the program. We do a number of placebo or falsification tests where we look at fake treatment groups. So we look at older and younger and older women who shouldn't have been impacted by the program at all. And we find no effect of the program on younger and older women. And we also look at some fake outcomes. We look at whether or not the tumor was diagnosed in the left or the right breast, whether or not there was any impact of the program on non-cancer deaths, for example. And in all of the different falsification tests, everything stacks up, and we don't necessarily find we don't actually find an effect. And that sort of convinces us that actually our identification strategy is appropriate. We also do a number of things to try and impact or try and estimate whether or not there's been any spillover effects. So we look at data in terms of whether or not there were increases in opportunistic screening in the control region over the period, and we don't find that to be the case. And we also look to see if there have been any increases in what are called DCIS cases, ductal carcinoma in situ breast cancer cases. These are non-invasive breast cancers that are only detectable via screening. And if we saw a large increase in DCIS cases, you know, in the post-screening era in the control region or in younger or older women, this would be indicative of a big shift into opportunistic screening, and we just don't find that to be the case. And then we also do some subsample analyses where we speculate that maybe spillovers might be more likely to happen, you know, across adjacent counties. So we do some subsample or smaller sample analyses of counties that are quite geographically separate, and again, we don't find any evidence that these spillover effects are happening. So what I'll do is I'll just finish up with a couple of concluding thoughts and summary of our findings. So obviously, as I've discussed, we examine the impact of a national breast cancer screening program. We find that the program works exactly like it should do from a health service perspective. We find large effects on the number of cases, rates of clinical presentation, late stage incidence, and case fatality. And the way we describe that in the paper is that this is consistent with what's called a survival benefit from a stage shift in diagnosed breast cancers. The program is picking up a lot of extra breast cancer cases, and many of those are early stage cancers. And by doing so, case fatality, conditional on being diagnosed, is going down significantly. But at the overall population level, we're not finding evidence that these are translating, these reductions in case fatality rates are translating into reductions in overall breast cancer disease-specific mortality. And in the paper, obviously, we discuss why we think that is. One possible reason is overdiagnosis, that maybe a lot of these cases that are extra cases that are being diagnosed are overdiagnosed cases. And we actually estimate an upper bound on the rate of overdiagnosis. And we find it to be, I think our estimate is 21%, which is sort of consistent with previous literature. And that would suggest that it's part of the story as to why we don't see this transfer from case fatality reductions into population mortalities reductions, but it's not the entire story. So what we do is we discuss the possibility that actually, major improvements in the effectiveness of breast cancer treatments, particularly for later stage cancers, since these older RCTs have taken place, that this is actually part of the story as well. And the other reason as to why we mightn't be finding evidence consistent with MARMOD, etc., is that it could just be that these programs are less effective now in an era where there's much greater awareness around breast cancer, and there's also maybe just the external validity of those RCTs actually is not as good as many people might have assumed. Okay, so in terms of implications, and then I'll open up, I can see a couple of questions coming through on the chat and the Q&A. Apologies, I'll get to those at the end. So there was a point raised in terms of the expansion of breast check to 65 to 69-year-olds. These, I guess, results would suggest that maybe we might want to think about, whether or not this is something we want to do. And that would be one of the important implications from what we've done. Haven't talked about it today, but we also don't find in the paper that the program is leading to any substantial reductions in disparities in breast cancer outcomes for lower socioeconomic status women. So I was somewhat surprised by that, but that's one of the findings. So it doesn't seem like these programs work for reducing disparities. There are caveats, as of course there are, as always, and these are just a few. Our analysis is based mainly on what's called the prevalent screening round, just when screening has been introduced. There may be benefits from repeat screening, and maybe it's that, this argument that interval cancers, these would be cancers that are detected in the interval between different screening rounds. So when you go between your second and your third screen, for example, that maybe the program works better for those than the prevalent round. We don't know of any evidence that says that that's the case, but it is possible. So maybe that's something that's affecting our results. As I mentioned earlier, this is what's called an intention to treat analysis. This is an evaluation of the program being rolled out in one area, not in another. It doesn't guide individual decision making. So no woman should look at these results and make a decision or be influenced by them in terms of whether or not they individually should attend for screening. We're absolutely clear that that's not what this particular analysis can do. And the other thing, I think, this is an important caveat in terms of this literature, generally speaking, looks at these very binary measures of survival or not, or has died within 10 years or not. It generally doesn't look at issues related to quality of life that might, be a direct result of less invasive treatment following earlier detection. We don't have data on that. We can't look at other clinical outcomes. So for that reason, this is another part of the picture. Our results certainly don't say we shouldn't have these programs, but they certainly would cast some doubt in terms of the overall impact at a population level in terms of the mortality. Okay, so what I'll do is I'll finish up there with the take homes and open it up for Q&A for the last few minutes. Thanks, folks.
Thank you very much, John.